broadcast of Doctors on Call is made possible by the following members of the Greater Northland healthcare community. Essentia Health, with 17 hospitals, 67 clinics, and 1,500 physicians and credentialed providers, focusing on the health of patients across Minnesota, Wisconsin, and North Dakota. Essentia Health, here with you. Integrity Health Network, physician-driven, patient-inspired, the strength of independent healthcare. UCare, improving the health of our members through innovative services and partnerships across communities. UCare, healthcare that starts with you. Hearing Wellness Center and the region's first tinnitus treatment center. Healthy hearing for life. Find out more at hearingwellnessctr.com. St. Luke's, providing compassionate, experienced care for communities throughout the Northland.
Good evening and welcome to Doctors on Call. I'm Dr. Alan Johns from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I will be your host for our program tonight on eye problems. We will be glad to take your questions on conditions like cataracts, contacts, macular degeneration, and glaucoma. The success of this program is very dependent on you, the viewer. Please call in your questions and we'll do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Charles Ahrens, an ophthalmologist with Ralph Eye Care Specialists in Hermantown. Dr. Timothy Quinn, an ophthalmologist with the Miller Creek Medical Clinic in Hermantown and the Hibbing Family Medical Clinic. And Dr. Kevin Tracy, an ophthalmologist with Austin and Tracy, PA. Our medical students answering phones tonight are Melanie Mester from Owasso, Oklahoma, Ryan Wilson from Wasilla, Alaska, and Marie Whippler of Parkers Prairie, Minnesota. And now on to tonight's programs on eye problems. Well, maybe we can start out with Dr. Ahrens. Just for general, could you give us a little anatomy lesson of the eye?
Yeah, sure.
So we have a model here and
Okay,
some
great.
pictures.
So basically, the basic anatomy of the eye for what I go over with my patients, I usually start from the front part of the eye and move back, starting with the cornea, which is kind of the clear shield of the eye that light passes through. And if we open up the model of the eye, behind that, there's a space in between the cornea and the iris of the eye, which is the colored portion of the eye. Through that, you may be able to see there's a small circular opening, which is the pupil of the eye, and that's where all of the light from the outside world passes through, and it passes through the lens of the eye. The lens is the last portion of the eye that bends light to focus it back onto the retina. The lens of the eye, as we age, becomes larger, more opaque and denser, and that's what a cataract is. As the light moves from the front of the eye through the lens, it'll then hit the back of the eye, which is lined by the retina, which is the neurosensory portion of the eye. Those cells then perceive the light, send neurologic signals back through the optic nerve to the brain, which is basically how we sense and interpret light.
Well, thank you. Dr. Quinn, so we hear a lot about macular degeneration. Where's the macula in all this?
So we can probably show you in two different diagrams. Functionally, precisely it's right at the posterior aspect, back of the globe, exactly where the light's focused, where the central vision is. So when you're looking at me, you're looking with your macula, and I'm looking at you with my macula.
How big is it?
Well, it depends on who's describing the anatomy. I would probably about 2 to 3 millimeters across.
So
although
it's pretty small. Right?
Yeah, and
Very
the
small area.
fovea within it is, I think, 300 or 400 microns, fractions of a millimeter, let's say.
So the whole thing is very tiny.
Correct.
Okay. very good. And Dr. Tracy, I guess since we're on the topic, I know this will come up later. What's macular degeneration then?
Macular degeneration is a disease of the macula, the reading part, the central part of the retina, and it's the most common cause for irreversible vision loss after age 65. So it's a very important disease because as our baby boomers hit the age of 65 and beyond, we're going to see almost an epidemic of the condition. And basically, those same rods and cones that serve us so well over the years start to wear out, and there is an accumulation of material and a breakdown of some of the healthy tissue, and it can be replaced by new blood vessels that can lead to scar tissue and severe vision loss. And that is about 10% of the macular degeneration is wet degeneration with new blood vessels. The more common type is dry degeneration that can wear out gradually. Unfortunately, we don't have a good treatment for the majority of macular degeneration. We're looking at ways of preventing it with nutritional supplements. There have been some developments with injecting medicine in that helps the wet degeneration. But it's an area of real intense research to try to hopefully prevent it and at least reverse it.
Thank you. Well, we have quite a few questions already. We have a caller from Tower, Dr. Ahrens, wanting to know, how does shingles affect the eye?
That's a great question, considering I just saw 2 today. Shingles it can be a very complicated disease, particularly for the eye. When we're talking about shingles, you know, the classic thing that we notice is a dermatologic distribution in a certain nerve pattern. So the most common type is you'll find the rash that starts on the trunk or wrapping around from the back. But the second most common is actually in the distribution along the forehead, which then also involves the eye. So you can have shingles on the eyelids themselves, but more importantly for functional vision, it can affect the cornea, it can affect the uvea or the tissues lining the retina and the iris and cause inflammation inside the eye. Inside the cornea can affect tissues within the retina and the optic nerve as well. So it's a very significant disease, and that can affect many parts of the eye and can cause vision loss if not treated appropriately and effectively.
Okay. Dr. Quinn, a caller from Duluth, what do halos around the lights at night mean? Does that mean anything?
It means there's something optically incorrect, so that the light isn't being focused properly and you're getting light scatter. That can mean something as simple as incorrect glasses prescription, dry eye, cataract, vitreous floaters, something like iritis, like you might see inflammation within the eye causing either swelling, corneal swelling, any opacity in the cornea, whether it's nodules or edema, which is swelling, anything that would cause light scatter.
Sure. Thank you. Dr. Tracy, here's a question. I bet it's pretty common. This caller from Duluth, her eyes get dry at night. Is this normal, or is this a symptom of something?
Well, dry eye syndrome, there's a wide spectrum of causes, but it is a very common complaint, and there can be a decreased tear production that can manifest itself through the day. There can be increased evaporation from the tear film due to some problems with the glands that secrete some of the oily layers of the tear film. Sometimes people wake up in the middle of the night with a very painful eye because there's been a breakdown on the cornea, either due to an old injury or just the makeup of the cornea. And so there's different treatments depending on the cause.
Thank you. Dr. Ahrens, this caller from Duluth has a wrinkled retina. What is that? Is that something bad?
It depends. The most common thing when we talk about a wrinkle of the retina, if we're looking at the eye, the main volume of the eye is a gel called the vitreous, and in just about everyone, eventually that gel will contract and that area gets replaced by fluid. But when that happens, a small scar tissue can form in the macula, like Dr. Quinn was talking about, and occasionally that can contract, and we can call that macular pucker, retinal wrinkling. And if that's the case, if if that's happening, it really depends on how badly their vision is affected. Oftentimes they can stay stable. Sometimes they can progress and cause worsening vision. If it gets bad enough to where the vision is significantly affected to where it's affecting their activities of daily living or impactful on what they're doing in their life, there is surgery that can correct that. There are other causes of macular wrinkling that may be a little bit more ominous. It wouldn't specifically be retinal wrinkling, but it could be folding in the back of the eye or things like that, which would have to be evaluated more thoroughly.
Sure, interesting. Dr. Quinn, caller from Superior, if you have LASIK surgery, are you more likely to develop cataracts later in life? Is there any correlation between LASIK and?
I don't believe there's any studies to demonstrate that as to be the case. There's some argument that it may be, but as far as I'm aware, no one's published data to support that connection. Theoretically, laser, that frequency we don't blame cataract for. It's usually ultraviolet, which isn't used during it. The pressure on the eye, any surgical trauma, any trauma to the eye can lead to cataract, and LASIK is surgery, so theoretically there could be, but I'm not aware of any data to support a direct connection.
Dr. Tracy, a caller from International Falls, her interocular pressure is increased. Is that something, are there things it can do that can slow progression of this, and is that glaucoma then if your pressure is increased?
We used to define glaucoma by pressure primarily, knowing that the higher the pressure is, the more likely it is people can develop glaucoma. There are many people with glaucoma that never have elevated pressures. There are many people with elevated pressures that never have glaucoma. So it's a piece of the puzzle that we have to look at. And the main question is, does the optic nerve, which is the cable running from the eye back to the brain, carrying about 1.2 million nerve fibers, does that show signs of damage? And if the pressure is elevated, then we try to lower the pressure. Even if the pressure is normal, we'll try to lower the pressure. That's one of the few things that can be done to prevent glaucoma damage.
Dr. Ahrens, Dr. Tracy was talking about macular degeneration some. Caller from Two Harbors is taking, does aspirin make wet macular degeneration worse, or should they take aspirin or not?
It should not make it worse. You know, using aspirin, I tell all of my patients that if your primary care doctor is recommending aspirin, there's a good reason for it, meaning we're trying to prevent heart attacks, strokes, and things like that. There's no obvious evidence to say that using aspirin will make wet macular degeneration worse. And so even if there was there has been thoughts that it may. There's no studies that have proven that it is, and so I think aspirin is perfectly healthy for that.
Thank you. Dr. Quinn, a caller from Tower, has choroidal folds. What is it, and are there any new treatments for that?
Dr. Ahrens addressed that briefly earlier as with the retinal folds or retinal wrinkles.
Is it the same thing?
Not exactly, but he did mention that sometimes there's something else. It could be pressing from the back, or you could have an inflammation that could cause folds in the choroid that can look like retinal wrinkles. That wouldn't be an epiretinal membrane or the macular pucker like you described, but saying that there's other things that need to be researched. It's something that should definitely be looked at further to figure out or determine why he's got the choroidal fold. Is there a tumor under it, or something behind the globe pushing it forward, or what it might be? In and of itself, it's not a concern, but to figure out why it's there might be.
Thank you. Dr. Tracy, a caller from Wisconsin. This is a good question. I'm sure a lot of people are interested in this. Please explain how cataracts start, how do they grow, and when is surgery needed?
Well, I think that is a good question, because that would be our most common cause of reversible vision loss as people get older. And it's a huge problem around the world. We've got millions of people suffering from blindness due to cataract. Basically, most people start off life, not all, but most, with a clear lens. Again, the focusing element that sits behind the colored part of the eye, the iris. And there are children, and that's why it's important that they be evaluated to make sure it's a nice, clean red reflex looking back, no opacities in that lens. But basically, as we get older, that lens can become cloudy. Certain medications like steroids can cause it. Cigarettes have been implicated in cataract. Sunlight exposure can contribute. But mostly it's an aging process where that lens continues to become more dense and more cloudy. The time to do surgery is not just because a person has cataract, but rather because it's interfering with their activities of daily living, as has been mentioned for epiretinal membrane. So when people are having trouble reading, driving, other things, it is reasonable to consider and discuss surgery.
Thank you. I'll ask Dr. Ahrens this question, caller from Duluth. Can LASIK surgery cure astigmatism?
Yeah, LASIK surgery, especially nowadays, LASIK surgery is getting more and more advanced, and the top lasers that we're using now are very good to not only just cure regular astigmatism, but also irregular astigmatism. So if you look at what astigmatism is, you've got the cornea, which, you know, for most people, if we're talking about what we ideally want in a cornea, should be like half of a basketball, a perfect half of a sphere. Well, regular astigmatism makes it more like half of football, where one axis is steeper than a flatter axis. So the laser, when we're doing the treatment, will correct for that. But the lasers nowadays can also correct for minor irregular astigmatism. So instead of being a perfect half of a football, it's got little undulations in it and little irregularities that can be smoothed out, and it's more adaptable to the individual patient now.
Thank you. Dr. Quinn, caller from Hinckley, has venous pools in the eye. What are they? Venous pools.
Venous pools.
Does that ring a bell? That's all the information we have. So.
Hard to say. Are we talking maybe about an angioma or perhaps a bleed where the blood's collected? I'm not entirely sure, but a venous angioma is generally a benign lesion. There aren't many either arterial or venous malignancies in the eye. In general, there's something you'd observe unless they cause leakage that can lead to swelling that might, if it affects the macula, reduce vision.
Kind of a hard question to answer without further information, I suppose.
Yeah. I'm not quite sure what they mean by a venous pool.
Sure. Dr. Tracy, a caller from Duluth, has been told that my eyes can't be dilated. Why would that be?
The most common reason a person is told that is because their drainage angle, instead of being wide open, is shallow. And the concern is that with dilating drops, the iris, the colored part, as it dilates, can press up against the drainage area, close off the route for fluid to leave the eye, cause a buildup of pressure, and that can be a very painful and potentially blinding condition called acute angle closure glaucoma. So,
is that something that's very common, or but?
It depends on the population you're looking at. Certain parts of the world have a bigger problem with that. But in general, it's probably less than 10% of most populations causes for glaucoma.
Okay, thank you. Dr. Ahrens, a caller from Duluth, wants to know, how do I get rid of my floaters?
Generally, floaters we don't get rid of. Floaters, if you remember me talking earlier, that gel in the back of the eye will separate off of the retina, and when it does that, I like to tell my patients that normally the gel is sitting back there, and if you have a clear sheet of cellophane stretched out, you can see right through it clearly, no problems. But when that gel separates off the retina, it crinkles up and then it moves around. Now, normally our eyes kind of get used to the fact that it's there, you know, over the first couple months that we have them, and generally our vision isn't that impacted. Now, if it's a large floater and it's sitting right in the center of the vision, and the patient is not able to do their daily activities, potentially there is a surgical procedure called a vitrectomy that could remove that. It's very rare to do it for floaters, and the patient has to be very motivated to get rid of their floaters before we would even consider recommending that, because there is risk to the surgery, and it's a significant risk. So.
And the caller, a different caller from Hermantown wants to know, is that a common occurrence with age? A lot of these
Yes.
things we're talking about, I hate to say it, are related to age.
Yes, very common.
Darn.
Very common.
I guess that happens. Okay, well, and there's another one, yeah, why about floaters. So let's see. Graves' disease in the eye for, that was for Dr. Aaron. Well, since for Dr. Aaron's, I guess there's a caller just for you. So how
great.
about Graves' disease? How does it affect the eye?
Graves' disease has, again, a lot of manifestations in the eye, just like zoster did, I guess. The most common thing that we'll see in Graves' disease is actually lid issues. You'll have retraction of the lid, which means the lid, instead of, you might see a lot of people with droopy lids, in these patients the lid will be elevated. And if you've ever noticed, sometimes patients with thyroid disease, particularly Graves', may have a staring type look, or you'll be able to see the whites of their eyes above and below their iris. And so that's probably the most common finding, but it can lead to other things too, drying out of the eyes. It can lead to double vision. It can lead to what we call proptosis, where the eye actually gets pushed out a little bit from inflammation and things behind the eye. It can get so bad and so serious that we actually have to treat it, because all that inflammation behind the eye can actually affect the optic nerve and damage it if not treated appropriately.
Okay. Dr. Quinn, here's another common eye problem. Caller from Cloquet would like to know, what happens to the eye with diabetes? And are there any supplements that can help prevent that?
Diabetes affects the eye in many ways, much as Dr. Aarons described for Graves' disease. Only I'd say even more so. It's about a 2-hour lecture. It can affect every structure in the eye from the front to the back. It raises your risk of cataract, which we've discussed with Dr. Tracy, particularly certain kinds of cataract. It can lead to weaker surface cells on the eye, the skin of the eye, you could say, leading to recurrent erosions or easy abrasions. It can make the eye more susceptible to harm, whether it's trauma in general or surgical trauma. Certainly raises the risk with cataract surgery or other surgeries for swelling, bleeding, these kinds of things. Having diabetes makes you more likely to get, or impairs your immune system, so you're more likely to get infections, and we have to watch for that with any part of the globe. Most commonly when we talk about diabetic eye disease, though, we're talking about retinal disease, whether that be abnormal vessels growing to try to refeed and repair parts of the eye that are deprived of blood flow due to the diabetic damage to blood vessels. All diabetic damage is related to damage to blood vessels, either leading to leakage or to loss of blood flow, and therefore what we call ischemia, or kind of starving, not enough oxygen or sugar, and all that can lead to vision loss, whether it be from swelling or bleeding or traction, retinal detachments and such.
Best thing to prevent that is diabetes, keeping diabetes in good control?
Most importantly, I always tell my patients, try to keep your A1C under 6.5. That equates to a blood sugar of around 100 on a regular basis, but the A1C monitors more closely. If they can keep their A1C under 6.5, I tell them they'll probably never have eye disease. I don't guarantee it, but I think that will. Avoid smoking. Anything that damages blood vessels, smoking, high blood pressure, high cholesterol, any lipid abnormalities, all the things that we would in general recommend for the health of our patients, but especially for diabetic patients.
Thank you. We have a caller from Embarrass. This is a question for Dr. Tracy. Does marijuana lower intraocular pressure?
Yes, a little bit, and no one recommends it for treating glaucoma. So it's not really, it's actually been used around different parts of the world in an eye drop form, but it's poorly tolerated on the surface of the eye, and it doesn't last very long or lower it very much.
Thank you. We just have a couple of minutes left. Dr. Aaron's patient calling in has herpes simplex in the eye. How do you get it and treat it? Is that something that's bad?
It's generally not bad. It can be if not treated quickly. Herpes simplex virus is probably one of the more common viruses that we see. You know, probably about 80 to 90% of the people by the time they're 16 are exposed to it. And it's the same type of virus that we see in canker sores or in cold sores. And so what can happen is we can get the same virus that, you know, has been lying dormant, and we get it in the eye. It can lead to corneal issues, lid issues, just like the zoster can. And again, antiviral therapy and then later steroids can help treat it. But as long as we do it quickly, usually there's no issues.
Okay, well, thank you. And we just have like a minute or so left. Just looking for a question. We had a lot of questions here tonight, a lot of good ones. Is a caller from Washburn, X-rays or photographs of the eye? Is that's done at times? I mean, like fluorescein angiography, is that what they're talking about, or?
Sure. Well, fluorescein angiography doesn't involve X-rays.
Right.
Occasionally you'll get a skull X-ray to look for foreign bodies in the orbit or in the globe, perhaps. But in general, we'll get CT, which is X-ray,
Right.
of course, but more localized. Fluorescein angiography, on the other hand, is more looking at the mostly the blood flow into the eye and
Sure.
looking for leakage or perfusion or transillumination defects, things of that sort, which is the fluorescein dye goes in the blood
Sure.
vessels and fluoresces under certain lighting arrangements and
thank you.
can look for damage.
Thank you very much. Well, we're out of time here. I'd certainly like to thank our panelists, Dr. Charles Ahrens, Dr. Timothy Quinn, and Dr. Kevin Tracy, and our medical students, Melanie Mester, Ryan Wilson, and Marie Whippler. Next week, please join Dr. Ray Christensen for a program on stroke and other neurologic problems, when his panelists will be Dr. Victoria Heron, Dr. Paul Sanford, and Dr. David Sproat. Thank you for watching, and good night.